All right, a very good morning to you. It's good to see you. It is exactly 8 a.m. and you are in time for your world. My name is Winnie Limbembe and today is Wednesday, and you know Wednesday is always Wellness Wednesdays, and we talk about anything and everything health related. And the point is to pass as much awareness out there as possible as far as, you know, different conditions that are concerned, and as well as lifestyle in general. All right, and today we'll be focusing on adenomyosis, and we'll be focusing on the treatments that are available right here in the country. And I'm pretty sure most of us have had a lot to do with endometriosis, but do we know anything about adenomyosis? Well, you want to stick around until the end of the show to understand, first of all, what exactly is adenomyosis, how different is it, or is it the same as endometriosis, and what are some of the treatment options that are available, who is at risk. There's so much to discuss on the same, and we have the perfect person to have or to hold this discussion, and we have Dr. Yamal Patel, who's a consultant obstetrician gynecologist from Third Park Hospital. Good to have you, Dr. this morning. I mean, I was telling you this when we sent off the poster yesterday. Everyone was like, "Please say hi to Dr. Patel. Please say." So I am saying hi.
Thank you.
On behalf of the people.
Hi to all of them too.
Right. And we'll also be joined by Agnes Marsha, who again will be here to tell us her story as far as adenomyosis is concerned. All right, but before that, we have a question for you this morning, and the question that we're asking is menstrual pain normal? All right, and what is your experience? For all the ladies who are watching us this morning, this question is specifically for you, and we're asking, is menstrual pain or cramping, as we all know, is it normal? All right, and what has been your experience? So our socials, that is NTV Kenya, both on Facebook and on X, is how you can reach us. Or if you want to share your views as well, our WhatsApp number is 0112500 and ask any question that you have. Dr. Patel is here this morning to answer all your questions. And Agnes is still is on the line with us, joining us virtually. Agnes, good morning. It's good to, I want to say see you, but I can't see you. But listen.
Good morning. How are you?
Very well, thank you. Please stay on the line. We'll be coming to you very shortly. And first of all, thank you for agreeing to speak with us this morning as far as your story and your journey with adenomyosis is concerned. So we'll be coming to you very shortly, but Doc, first things first, because like we said, there's so many conversations around endometriosis and adenomyosis and cramping all together, and is it normal? Depends the pain, is it normal or not? So can you first of all just get to understand, I want to say like a woman's reproductive system in its all, but with a special emphasis on the uterus and endometrium and all those steps, and then I'll come back and just ask a few questions that some people sent.
Right. Thank you very much, Winnie, and good morning to all of you. My name is Dr. Yamal Patel. When we talk of the reproductive system in the female, we would say it is composed of basically the uterus, with the tubes on the sides, and the two ovaries, which are the organs that actually produce the hormones that are feminine in origin.
Okay.
And then the uterus has its opening down at the cervix, and then you have a vagina up to the outside, which is the vulva. All right. Now, in the uterus, we have three layers that we need to know about, basic layers, and then we can subdivide them. The three layers are the inner lining, which is the endometrium. That is the lining that grows every month in preparation for a possible pregnancy. And if pregnancy does not ensue because no one was trying, or for some reason it didn't work or whatever, that lining is what is shed out as the periods.
Okay.
So that is the lining, which is the functional part of the uterus. Then we have the muscle layer, which is called the myometrium. So the muscle layer is actually what gives the uterus its ability to contract. So whether it's contraction during periods or whether it's contraction during labor, that is what contracts. And then we have the outer layer, which is called the serosa. So basically, these are the three layers of the uterus.
Okay.
And these diseases we are talking about are revolving around these layers of the uterus.
Okay. So the focus today is on adenomyosis.
Yes.
But we've heard a lot more about endometriosis.
Yes.
And even the statistics say 1 in 10 women are diagnosed with endometriosis, right? So what is it? Is there like a distinction between the two, or is it maybe one and the same? Does one cause the other?
So they are relatively distinct.
Okay.
And you can have one without the other, but very many times you can have them together.
Okay.
And of the two, we know for a fact endometriosis is seen in around 1 in 10 women worldwide. But adenomyosis, on the other hand, is even more prevalent.
Oh, really?
Yes.
Okay.
So we found it in the past to have a prevalence of around 20 to 30%. And with recent studies, it's a very variable range, going from 15 to 70% in women.
Okay.
And many of them go sometimes unnoticed. And the reason is the adenomyosis may have slight different behavior in how it forms than how endometriosis itself forms.
Okay.
So they are distinct, but they have some similarities, which is what we'll be discussing.
Okay, absolutely. And before we speak to Agnes, then can we understand how distinct they are?
Yes.
So that I can see you have your model here.
Yes.
So yes,
I think this visual, it gives a visual. So I would like to understand, I mean, for the viewers to understand this part.
All right.
So this is what I say. This is the inner lining, the one that grows and sheds, this pink part.
Yes.
It grows and it's shed when there is no pregnancy.
Okay.
It's called the endometrium.
All right.
This red part is the muscle. And this outside is the serosal layer. These are the tubes, the ovaries, and the vagina with the cervix. So when these lining-like cells grow outside the uterus, so you can see this is outside, that's outside, that's outside. So all these areas, the ovary, this is endometriosis. So it is endometrium-like tissue.
All right.
Proliferating outside the uterus, and it has the ability to infiltrate into the surrounding structures, these ones. That is endometriosis.
Can you sometimes like get to the, because I've heard that people say it can also get itself into the lungs?
Lungs is pretty common. It has gotten itself even into the brain and the eye and the nose and the lips and the nails. We've seen it that far.
How?
Yes, so that's what I said. It's a very poorly understood disease, but it can go anywhere. We've seen very weird locations, including, let's say, in the eye. You can imagine someone actually having tears of blood because they bleed when they have periods. So so it's a very weird condition. So the lung is relatively still more common than these other ones. So basically it can go to any part of the body. Let's put it that way.
Okay, all right, I see that.
All right?
Okay.
So now, when this endometrium, the glands and the stroma start infiltrating into the muscle, now this is adenomyosis. So this is adenomyosis, this is endometriosis. So you see they are both similar in one aspect, that they have endometrial-like tissue or glands growing in a place they should not be growing. But one is within the wall of the muscle, and one is way outside.
And sometimes can find itself in places they're ideally not supposed to be.
Oh yes, and they might be together, coincident, but they might be individually present. You might have endo without adeno, you might have adeno without endo.
Is it possible to have both?
Very commonly, actually more commonly, to have them coexist. Yes.
Okay, I'll come back to you then to understand. So what are some of these symptoms? Because I know we've mentioned something to do with pain. And I know sometimes pain is relative. There's some people who have like higher tolerance when it comes to pain, and bless you if you have higher tolerance to pain. And there's some people who have very low tolerance to pain. But like we always say, pain is relative. So then how much pain is not normal? But let's speak to Agnes first, and then we'll come back to you, Dr. So Agnes, thank you so much for staying on the line with us. Someone who's watching us this morning would like to understand, so a little bit about your story and your journey before you got your diagnosis for adenomyosis. What was it like? What are some of the symptoms that maybe you presented with, and when was that?
All right, so I started having heavy bleeding back in 2022, and I had this excruciating pelvic pain that I didn't understand why, and also the cramps were so severe to a point like I couldn't do much during my menses because my body was very weak. Even trying to take painkillers at times, it couldn't work.
Yeah.
And due to the heavy bleeding, my blood levels started to become low. So the pelvic pain was the one that did not do me justice, if I could say, because it was very bad. Yeah. So when I went to my gyna, then after doing a bit of ultrasound, they said it was a degenerative fibroid.
Okay.
And that's why it was causing so much pain. But the pain continued until my sister was like, can we go for a second opinion? So that's why I went to Dr. Yamal. And when he did the ultrasound, the examination and all, it's the time that he told me now that was not a degenerative fibroid. It is adenomyosis.
Okay. And just to pause on that, Doc, is this something that you see a lot, that confusion, misdiagnosis? Because again, even when I was reading about adenomyosis, it says this is one of those conditions that it's not diagnosed and properly diagnosed, and most of the time it's completely missed out, and until sometimes it's almost too late. So is this something that you see a lot, missed diagnosis of adenomyosis?
Yes, actually both the conditions, both endometriosis and adenomyosis are pretty often missed out, and it's a known fact that these conditions have an interval of close to 8 to 10 years worldwide from presentation to diagnosis.
Yes.
That
is a long
time. The history is usually hopping of clinics, hopping of doctors, not getting the solution. So it's not Kenya. It's not Kenya. It's world over.
Okay.
Even in the Western world, the minimum delay is around 8 to 10 years.
That is such a long time. And I can only imagine the pain and until you get that diagnosis, so that you know what exactly you're dealing with and get the necessary treatments. But why degenerative fibroids? Why sort of like the assumption that could be
so let's a fibroid. Now again, this is a fibroid.
Okay.
And this is adenomyosis. They are both in the muscle.
In the muscle.
So it's common to misdiagnose one for the other. So unless you actually are someone who is an expert at this, to be able to differentiate the two, they would sometimes mimic each other. And more so if you get what is called a focal adenomyosis or an adenomyoma. Those are extremely difficult to rule out from a fibroid. Diffuse is another version, but diffuse is still a bit easy because it's all over the uterus. But focal would be focal like a fibroid. Now, to differentiate these two requires a different type of training and skill set here.
I see that. And also Agnes mentioned pain and severe bleeding, and I'll come back to Agnes to just describe that pain to us, because majority of the times when people talk about pain, not everybody gets when someone says, I am in so much pain, I cannot move, I cannot go to work, I cannot do my day-to-day activities. So when we talk about pain and severe bleeding in this case, because there's some people who have severe bleeding that might not necessarily be adenomyosis or endometriosis here. So when we speak about this two, pain and severe bleeding, to what spectrum, I would say, are we talking about?
So I think very important to clarify one thing. You mentioned some people have a higher tolerability than others. I would look at it differently.
Okay, all right.
Let's understand what pain is. Pain is a body response to a nauseous stimulus. So it's not a stimulus that when if I touch, this is smooth, it's not going to pain. So it's a nice stimulus. Okay? But a pinch is a nauseous stimulus. So please, let's understand one thing first. Pain in whatever form, anywhere in the body, is abnormal, number one. It's your body warning you that something is not right. So pain in the head, headache is pain. Pain in the backache is a problem. You can't say this backache is normal. Pain is pain.
Okay.
You get it? So that's number one.
All right.
Then we go into the categorization or levels of pain. Why would some people get more pain than others? So we have what is called a scoring of the pain, and even in when patients come to see me sometimes for pain-related issues with fertility, I mean with periods, I sometimes have a chart that I show them. Say from a level 0 score to a score 10, and it actually describes what each one would mean. What level do you consider yourself? So anything that's above 6, 7 and above is considered severe. So that will tell you, oh, it interferes with my routine. I cannot get out of bed. I may miss my school or college. That's how you describe it slowly. So pain is abnormal.
All right.
So period pain is abnormal. Now that's what I'm trying to tell you. It doesn't matter how much. So you know, when we grow up, these our young kids are tuned to believing that pain is sometimes normal. So that's the thing I'm trying to avoid. Don't normalize pain. Have it checked, because something is wrong, that's for sure. So don't normalize pain. So when you have your elder sisters, your aunties, your mother telling you, stop being a sissy, I also had pain. She also has it. Why is it that you have to behave like this? 100%. So you see what happens? You start getting into a corner where you don't want to open up and tell people, and you try to brave it. Like, no. I mean, my sister did it. My friends do it. Why am I crying always in pain? So you try to brave it. With that, some people get that tolerability going higher. So you think this one has pain, but she has a very high tolerance. No. She's just been mentally tuned to believe that you shouldn't be crying in pain. This is what I mean. Some people, when we talk of labor, how do people respond to pain in labor? Labor is one of the most painful things a woman can undergo, or a human being can undergo. Some respond by crying, some respond by shouting, some respond by going quiet, some respond by pinching their husbands in labor. So you see what I'm saying? Different responses. So the ones who are quiet are not experiencing less labor pain.
And someone might actually say, but this one is quiet, so
it's not less labor pain. It's you mentally tuning yourself that you will not shout. The one who is shouting does not necessarily have the worst pain. So see the difference? That's mental tuning. That's exactly what happens here. If you tune yourself to believe this is normal, you start behaving like this is normal until it gets out of hand. That's what we should avoid.
Wow. Okay. And you know what someone actually said, Sylvia and Jue, when we sent the question, asking, is pain or cramping normal, and what has been your experience? So Sylvia said, I have always heard that it is not normal, but every time I see a medic and explain my situation, they say it's normal. I think there is a confusion on the extent of pain. I've always worried about it, especially when they link it to endometriosis and other illnesses like PCOS. So clearly, even amongst them, there's still that confusion.
No, there is.
That's what's normal and what's not. But what you're saying is pain in itself is not normal.
Not normal.
What about like slight discomfort?
Discomfort is different. But still, having it checked, discomfort will never interfere with your day-to-day life. Discomfort will not require you to pop a pill. The moment you need to take a painkiller to quieten it down, it automatically goes into not normal. And then you have to start looking for why not normal. So I'm not saying every pain in period is endo. Don't get me wrong. But I'm saying it needs to be checked. And then we now follow it up from there. So not every person who comes and walks into my office with pain has to have endo or adeno. But you have to start thinking that direction and then rule it out unless otherwise. That's what we do.
When I was reading as well, and it's still on the adenomyosis, they said there's some people who do not present with any symptoms. And I'll come back to you to then help us understand how is that this other person is, showing all this manner of symptoms and pain being one of them. And then there's this other person who has completely no symptoms at all. But let's speak to Agnes. So Agnes, the first gynae that you went to see told you that you have degenerative fibroids. So what was that like in terms of your understanding on degenerative fibroids, and what are some of the treatment options that they prescribed? Because like I said, it did not help and you had to seek help somewhere.
So for the degenerative fibroid, I was told that it's reducing its size, so I shouldn't worry about it. With time, it will finish its degenerative state. But I didn't understand why the pain was so much, because it was actually, if I could say, even more than 11 out of 10, because it was a very strong pain that, it's very excruciating, something that I can't even wish on my worst enemy. And on the heavy bleeding, I could change my pad every hour and it's full. And if I'm not careful, then I can soil myself. So that's how heavy the bleeding was. And the pain. So I really didn't understand why a degenerative fibroid could cause all that. Yes.
Okay. All right. So you went to seek further, and also speaking on pain. I know when you speak to a lot of women, they'll tell you, there's pain on my back, and then there's pain on my sides. Like every single part of the body hurts. So I wonder, what was that like for you? Did you experience more on the back pain, or just every single part of your body and muscle hurt?
Pelvic pain on the pelvic area. That part, the pain, I could literally cry, fold myself in bed, try to take painkillers. It couldn't work. And I just cry until you fall asleep. You cry mpaka unachoka hata kulia, and then you just fall asleep. So it was on the pelvic area. Yes.
And I can only imagine how, because sometimes you get that slight discomfort during your periods, and it's just uncomfortable, the discomfort. But so I can imagine that level of pain, what that must have been like for you and so many other women who are really, struggling with the same and don't really know what they're dealing with. So you decided to seek, further help, just to get to understand why is this pain not going away, or why the condition is not getting any better. So what was like your first place that you sought help, and how different was sort of like your diagnosis process as compared to the previous one?
So after my sister told me to go for a second opinion, so that's when I went to Dr. Yama. I explained to him the symptoms. Then he told me, now we need to do several examination, so to see what exactly is the matter. So what I liked is he did the scan himself. He was not depending on a sonographer to give him the results of a scan, which actually that was on the previous gynae, because I was sent to a sonographer. The sonographer did the scan and did his the results. So then now the gynecologist reads and translates. But for Dr. Yamal, he's the one who did the scanning himself, and that's why he was able to say, no, this is not a degenerative fibroid. This is adenomyosis. This is how it represents itself. Check your uterus. It's bulky. It's this way and that way. And I felt comfort, because now I know what I am dealing with. Yes.
I can only imagine the fact that now you know what exactly you're dealing with. It's sort of like a relief sort of in itself. And I want us to step back a little bit to when you talked about pain, and sometimes you're not able to go about your day-to-day activities. So many people respond differently to that statement when people say, I am in so much pain, again, during my periods, and I cannot move. Some people are stigmatized, for the same, like, how different do you think you are? There's some people who handle pain and go to work and all those things. So did you get like any of this negative, I would say feedback experience with pain in itself, that people didn't really understand what was going on?
So at work, I used to hide what I was feeling. So I didn't get any stigmatized because people will ask me, are you okay? I'm like, I'm not just feeling well.
Yeah.
But deep down, the pain was chronic. But at home, thank God I have a supportive husband. When I told him I am in pain, he used to really support me with just being there, try to get pain reliever for me, or to get hot water bottle to relieve myself, So the way Dr. Yamal was saying, you're tuned to...
So much just hide and think it's normal.
You hide and think it's normal, and it's not. Yeah. So at work, I was like, let me hide myself. I don't want anyone to see that, and I don't want to tell people that I'm having a chronic pelvic pain.
Yeah.
So, yeah.
Yeah, and I see that because the reason why I'm asking that, I've heard stories of women who've been fired from places of work because you can imagine every single month, several days in a week, they're not able to go to work because of this excruciating pain that is not understood by so many people. Or others have been outright stigmatized, and called names, being weak, like Doc, you pointed out. So then can we talk about some of the symptoms? I know we've mentioned pain and talked about pain at large, but what are some of these other symptoms? And also the other question on, so people who do not present with any symptom at all.
So, yes, I think it's important to understand adenomyosis as a disease that causes certain symptoms.
All right.
You've heard the most classical symptoms would be these two: heavy menstrual bleeding, enough to start causing anemia. So it's really heavy.
Yeah.
And the second one would be pain, especially worse a day or two periods, and then the worst is day 1, and then probably day 2, and then it slowly might improve. So these are pain and heavy periods, classic. But then there are other things that we sometimes ignore, but can be due to adenomyosis.
Okay.
Heaviness in the lower abdomen, backache. These women do have more backache during periods.
Lower backache or
lower
upper?
backache? Lower backache.
Okay.
And then, very often forgotten, many of them have issues with fertility. All right, so many times now I come across women who are trying to get pregnant, and adenomyosis is not helping.
Yeah.
And these are women who even sometimes have failed IVF cycles. All right, because when the adenomyosis is infiltrating into the layer that is just close to the endometrium, it makes this area very unfriendly. So you put a pregnancy here, even with IVF, it doesn't stick. Okay. So when it is that, it's also another symptom. And if you handle the adeno, you actually improve their fertility many times.
Okay.
And one more, which is very recently uncovered and very important, is pregnancy complications. So miscarriage rates, preterm labor, poor growth of the baby, IUGR, sometimes related to preterm labor, preterm rupture of membranes, excessive bleeding after delivery, so PPH. Yeah. So because it prevents the uterus from contracting very well.
Yeah.
So these are pregnancy complications. To the extent now, Winnie, I at the moment have a whole database and a diary in my office on my table that reads adeno in pregnancy. All right?
Wow.
And I have close to 50 to 60 patients who are in that book who are currently following up with me for pregnancy. And I kid you not, if I open the book page by page, majority of these women have at least had some poor pregnancy outcomes before.
Oh no.
Now I'm handling them in a different way. Yeah. So basically I'm doing some form of a research
I would say,
and I'm trying to see if there's a way we can improve the outcomes of these women. So this is a major issue which is forgotten. So we remember pain, we remember heavy periods, but we forget these parts which are major issues as well with adenomyosis.
Yeah. And even when you point out so infertility and even pregnancy complications, because there's usually a lot of, again, information around, so if you have endometriosis or you have adenomyosis, then you will definitely not get a child. And so many women, are devastated. But can we just handle that misconception?
That's a wrong
before?
statement.
Yes.
They can all have children,
100%,
but they will have some challenges and may require help. That's how it should be put.
Yeah.
To stigmatize a woman to say this means no possible pregnancy is not right. But it means that, yes, they definitely need help.
There is that risk, right? Yeah. And I'm happy that you mentioned that because, again, like you said, there's a lot of mis and disinformation out here that end up, causing more stress and harm to so many women. We're about to go on a break, but before that, the question that we're asking you this morning is pain, this is during a period, or cramping, is it normal? And what is your experience? Let's get to hear what some of you have to say. And someone actually said that, no, it is not normal. I actually have to go to the hospital to get painkillers through a drip.
Yeah, that's extreme now.
Right?
That's extreme. That's what I say. That is now in the level of 9 or 10 out of a 10.
Yeah, and that is too much. Yeah. Masim Wende says, what can I use? What can I use? It's even causing hormones imbalance or hormonal imbalance. Doc, I think you will handle this after the break. Someone, Mary Marie says, don't remind me, I still have one more to go for this year. My back and lower abdomen hurts like hell. I am really sorry, Mary, for that. Redemptor Muchua says, I didn't you feel akoka feeling? Okay, wow, all right. Yes, we get what you're trying to say, Redemptor. But someone else says, this is Chiptak Korongo, who says, what is the remedy of early menopause at 24? So Doc, maybe knock that down. What is the remedy for early menopause? And then Natisam Greg says, I don't think it's normal. It hurts badly. All right. And then let's get to hear what someone else says. Pamela Minayo says, my daughter is suffering from this period thing. I have tried, but I think that is an incomplete statement. So we'll try and get the full statement for the same. And then Janet Okwat says, mine is very, very painful. I want to imagine. Kindly, how can I get the solution? And Janet Daktari is here today. If you want to call in again, feel free to do so that you explain further to him. And then at the paparazzi, he says, I have never seen mine since I was born. Hell. Okay, this is wow. All right. At Bell African says it's normal, but the last day where go huma. But Daktari says it is not normal. Pain is not normal at all. So maybe get that checked. All right. Maybe one more before we go on a break. All right. So keep sending them on our socials, and that is at NTV Kenya, both on X and on Facebook. But again, like we said, use our WhatsApp number as well. That is 0112 500 400. Once again, 0112 500 400, and ask any question that you have or any clarification as far as adenomyosis rather is concerned, and this whole pain thing. Okay, and Dr. is here to answer all your questions. So for those who asked your questions, allow us to go on a break, and then when we come back, we'll pick up from there. And Dr. will answer all your questions. And Agnes, please stay on the line with us. We'll see you after the short break. All right, welcome back. 37 minutes past the hour. Time flies, and there's so much that we need to cover as far as our conversation this morning on adenomyosis, and we're focusing on the available treatments right here in the country. And Dr. actually points out a very important thing, and that is how do you decide, okay, not you, but specialists, how do they decide a form of treatment? And we'll also have Agnes Marsha, who's an I don't want to say adenomyosis patient, but she is here to, tell us her story as far as adenomyosis is concerned, and joins us virtually. Dr. Before we speak to Agnes, can we then understand some of these risk factors? Because I know we've talked about the symptoms a lot during the first part, but what are some of those things that predisposes someone to adenomyosis?
Yes, I think that's an important thing. So which women or girls are likely to develop adenomyosis? We've been trained traditionally to believe that it usually used to start in the age groups of 30 to 40s. But nowadays we are seeing in very many younger girls as well, even girls who in the teens. So that theory is slowly now diminishing. But yes, even today, the highest incidence is in that group of the late 30s and 40s. The second one is multiparity, which means having more children predisposes you to adenomyosis. And another one is having multiple or prior uterine or pelvic surgeries. So any previous surgeries on the pelvis, on the uterus, be it a normal delivery, that's a procedure on the uterus because you've delivered it, the baby through the uterus, a miscarriage, a termination or an abortion, a myomectomy, a surgery for removal of a fibroid. So anything like that would predispose to some of these endometrium-like cells, the lining cells, now go and grow into the muscle. So these are risk factors. So even multiple, miscarriages, which are for other reasons, or it could be related to this, actually predispose them to adenomyosis.
To adenomyosis. And then the whole conversation about treatment, because again, like Agnes said, so the first diagnosis, she was told something different, right? And of course, treatment option was given to her, but that did not completely help. So let's speak to her. But then again, there was also a question that someone asked, I think they're 24 in the early menopause. Okay, not related to the topic this morning, but do you want to just maybe touch on it a little bit and then we'll speak to Agnes?
Yes, so on those questions, maybe just quickly commenting on them. The one that is, that touches is the one of, oh man, I can't imagine there's still one more to go this year. So you imagine what kind of a fear that person has for the periods. That she's saying, I still have December to go. I can't wait for this to end. And then when December ends, she'll be like, oh man, come 2025, it's a new year resolution, but my periods are not taking a new resolution. They are behaving the same way. So you see, that fear, that's touching, but it's how their life is. The one of early menopause, we would call it premature ovarian failure, and may need to be assessed further as to why, but I don't think adenomyosis is a responsible factor here. But it could be related to previous ovarian surgery or previous, let's say related to endometriosis that damages the ovarian reserve, or some form of abnormal ovarian tissue where you have what is called streak ovaries. They're small and they actually go into menopause early. So it's called premature ovarian failure. Hormone imbalance usually is not caused by adenomyosis. It mainly it doesn't impact the hormonal structure of the ovarian function. And a teenage girl who had severe pain, I think yes, don't ignore it. That needs to be ruled out. It could be endometriosis, could be a cystic adenomyosis, which is a type of a very severe form of adenomyosis. I remember there's a surgery I've done 2 years ago on a young girl, 14, 15 years old. You should come and see her today, running around in school, doing art and happy. But trust me, she had gone down even in her schooling because she just couldn't concentrate. And she had what we call a cystic adenomyoma. So we removed that in total and she's absolutely okay. So that needs to be checked out.
I see that, and then, so Agnes, so went to see Dr. Patel. Now you have an actual diagnosis that this is what you're dealing with, and that is adenomyosis, right? So do you want to take us through that journey after you got your diagnosis and up until where you are at today? How are you? And basically how are you feeling?
So after the diagnosis, now Dr. Amal told me now this is a journey. We go step by step on addressing the issue. So he told me about my risk factor. It was because I had myomectomy back in 2021. So that might have caused the adenomyosis. Then he went again to explain to me the treatment. And since mine was, can I say, towards severe, but not so severe, I had to go for surgery to debulk it, just to remove a part of it, because again, it can't be removed, all of it, because my plan is to have babies in future. So he said we can start by debulking, then we do suppression of the remaining adeno, and then after that we go now to trying for pregnancy. So it's a step-by-step, it's a journey that needs a lot of patience, a lot of understanding, and a lot of support. Yeah.
I see that. Pain, again, because like you said, when we started the conversation, excruciating pain, you couldn't do your normal, day-to-day activities like go to work, for example, and then also severe bleeding. So has that improved over time?
Yes, after the surgery, the pain has reduced significantly. Actually, I had my periods the last few days. I didn't feel any pain. My sister was like, "Are you sure?
Yeah.
Are you okay?" I'm like, "Yes, I didn't feel any pain, just a bit of discomfort, kidogo." Yeah, not much, just kidogo, the discomfort of periods, But pain, there was no pain, and also the bleeding had significantly reduced, because now I could stay with my pad for like 4 or 5 hours, unlike before. So I can say I'm feeling great now, as in now I'm able even to come to work without even trying to hide that I'm in pain or
you're not okay.
to feel, exactly. The surgery did wonders, and I'm forever grateful.
Yeah. Oh my, wow. Okay. I can even hear from the tone of your voice when you say you're feeling much, much better, and it's really, really good to hear that. Doc, so one thing that she's mentioned, I think you also mentioned, and that is myomectomy might predispose someone to getting adenomyosis. And now this is my brain thinking, so the fibroids have been removed, right? So how does that maybe put one at risk of getting adenomyosis?
So I don't say all myomectomy patients will end up with adeno.
Yes.
But it is a risk factor as long as it's a uterine surgery. And the risk factor is higher if the cavity was opened during the myomectomy.
Makes sense, yeah.
So you see some fibroids go very deep. When they're very deep into the cavity here, and when you're removing it from here, this cavity opens, I've exposed this endometrium to this muscle. And then I stitched this up. But I stitched some of these cells in here, and then they start growing. So that's one of the theories. So as I've said, I mean, it doesn't mean all patients with fibroids will end up with that, because the next thing you'll hear is people being afraid of myomectomy. Like, oh, you'll remove this, but now I'll have adenomyosis in 2 years. It's not always the case. It's a rare occurrence, but it happens.
It could happen. All right. So the other question on the treatment options, and how do you, as specialists, decide on the treatment options?
I think before, very important question, I would say, before we decide what treatments we have available, I think it's important to decide how do we decide what treatment to offer
in the first place.
So it is supposed to be individualized. That's why it's important. It's not like malaria. You have malaria, it's one treatment, and it's curative. With adeno, it's more of a long-term treatment plan. How do we decide? On age. Number one. So my options for an 18-year-old, for a 30-year-old, and for a 45-year-old will be different.
Completely different.
All right. Number two, symptoms and the severity. It would change the treatment plan. Future fertility desire. Does this woman consider more children? I told you one of the risk factors is multiparity. So if she already has 3 children, is not considering more children, my treatment plan would change.
Will be absolutely different,
Other associated diseases. Many times adeno is not alone. It's with fibroids, or it's with endometriosis, or it's with pelvic congestion syndrome simultaneously. Treatment plan has to encompass the whole thing. You don't focus on one of the 4. Side effects of medical treatment. So when I'm talking of treatment, I also have to discuss and decide based on what possible effects with this medication that I'm going to offer give this woman in the long run. How long will I be able to give her this medication? You have to keep that in mind when planning treatment. Cost and availability. You don't just write medicine, go buy it, and then let's say 80% of her salary goes in considering to buy that one medication for the month. How is that practical?
No,
so keep that in mind. Is it available? You write it, but she has to import it from outside. How is it going to work? So this is how we decide. And then finally, the patient's wish, the preference, the goal.
Yes.
If she tells you, my goal is the pain, we focus on how to improve the pain. All right? So it has to be goal-based or preference-based. So this is how we decide first, what do I tailor-make for this lady?
Option,
Then we start offering them the options.
Okay, I see that. And again, the options are different again, like you said,
yes.
Surgery, we've heard of hysterectomy as well. We'll discuss that in a bit. But just to elaborate on what Agnes mentioned, for her case, it was to, first of all, debulk and then suppress. And then later on, like you said, it's a journey, okay? So you want to help us understand what this two mean, and then also talk about the different options.
So we'll start with the options, all right? So I basically divide them into two groups. One group is medical, and one group is surgical.
Okay.
The medical group should be our first line. First line, armamentarium. We don't always jump there. But in some very severe cases, we can go directly to that side. Medical group has painkillers and a variety of them that you can offer during periods and tell them, take this, it will help you. And that's what majority of the women anyway take, ranging from simple tablets to injectables during periods. But is this a treatment that is helping the disease? No, it's only symptom relief. So the disease continues, but the symptoms are suppressed. So it's never good alone because the disease is progressive.
All right.
Then you come to suppression. So medical suppression comes in the hormonal group. Because adenomyosis as well as endometriosis are hormonal responsive and estrogen based or estrogen dependent.
All right.
Anything that suppresses these hormones and estrogen will suppress adenomyosis as well as endometriosis.
All right.
So broadly, they're divided into two groups, pseudo-menopause and pseudo-pregnancy.
All right.
What we mean by that is anything hormonal that mimics menopause or creates a false or artificial menopause-like scenario suppresses endo and adeno.
Okay.
Anything that mimics pregnancy suppresses adeno. So in this group comes the progesterone groups. There is the coil like Mirena. There is the pill like Visay and Dynogest. There are some progestin pills, combined pills, the contraceptive pills. When used in a different format, how we give it is different. It will suppress. Then we have the other group that is called GnRH analogs. So those are injectables, but they can't be used for too long because of the side effects.
Okay.
And we have other groups as well, the selective estrogen receptor modulators, etc. Aromatase inhibitors, etc. So this is medical.
Okay.
Now we go surgical. Surgical is again divided into two broad groups, excisional surgery and non-excisional surgery.
All right.
Excisional means cutting out, and non-excisional means there is no cutting. So non-excisional would be things like embolization, uterine artery embolization. It's done for fibroids, it's also done for adenomyosis. But it has the challenge of sometimes embolizing other areas and causing premature failure. So not a very good option for someone considering future fertility. Then there's something called HIFU, high intensity focused ultrasound. Not at the moment available here, but it's also a very good novel technique for women planning future fertility, where they use focused ultrasound to heat their lesions and burn them, and therefore retain the uterus integrity. It's a good option, has shown promising results, but yet to come here. It's quite an expensive method. There is MR guided focused ultrasound as well. So instead of ultrasound based, it's MR based. Then there is also microwave and radiofrequency ablation. So these are all focused on only one thing. How do we destroy these lesions by heating it or damaging it or something, but leaving it there? And the recurrence rates are there as well, and sometimes high. Then we go excisional. Excisional is you excise and remove. So that's what we mean by debulking or cytoreduction. Remember, adenomyosis is in the muscle. So you can't remove all of it. If you remove all of it, this wall is missing.
Yeah.
That uterus is useless. It has a hole on one side. So how will it now carry a pregnancy? So you can't do excessive debulking, but you can do focused and judicious debulking, cytoreduction. That is one.
Okay.
The second one would be, if it is a focal disease, it's very easy to remove all of it. If it's a cystic adenomyoma, it's very easy to remove. So those ones definitely need excisional surgery. All right? And then there is the curative treatment. The only curative treatment is hysterectomy. When the uterus is gone, so is the adenomyosis with it. But it's not an option for women still planning future fertility.
100%. Yes. And I really like that you're pointing out all these available options, but also what informs a specialist's decision to offer what type of treatment. We literally have a few minutes to go, but a few questions for you. So this is Njoroge Wilson on Facebook, who says, when is dysmenorrhea? It's always painful, but you can have some NSAIDs, I think, for the pain. But if you note any change in the blood vessel or color, smell, amount, all those things, visit a gynecologist. But dysmenorrhea, can we just address that? I think you mentioned this a little bit, during the first part, but for the sake of the person.
Yes.
Yeah.
So dysmenorrhea literally means painful periods, okay, in simple words. And dysmenorrhea is divided into different types. There is primary dysmenorrhea and there is secondary dysmenorrhea.
All right.
Primary means without an obvious cause and usually related to excessive production of the inflammatory markers around the periods, and therefore the uterine irritability is more, it cramps more, and it causes more pain. And this is the type that sometimes we used to hear women talk about, that my periods were quite painful before my first childbirth and then the pain went. That's primary. Then there's secondary. Secondary means it's secondary to some cause. So it could be secondary to adenomyosis, secondary to endometriosis, secondary to a submucous fibroid that is causing cramping, secondary to a polyp, secondary to pelvic congestion syndrome. This is secondary. So when you have painful periods or dysmenorrhea, it's good to have these at least checked and then be categorized. Am I secondary or am I primary? All right? That's when you can proceed from there. The NSAID is just a painkiller, but it's not solving the problem. It's only suppressing the pain. It's like, I have a headache today, you tell me take Panadol. I say, oh, it went. Tomorrow, oh, another Panadol. Day after, oh, another Panadol. How many Panadols will you keep on taking? Instead of that, why don't we now start checking what is causing this person a headache every single day? You get it? So we need to go to the cause, not always give Panadol for headache.
That's I see that. And most of the people would actually go for the next available painkiller just to deal with the pain for that moment.
Which is not
solving,
right.
Which is not right. Thank you so much, Doc. Agnes, because we literally have like a minute to end the conversation. So like you said, this is a journey. You have started with Dr. Patel. You're feeling much, much better today. And there's, you're preparing, I wanted to say, for babies, which is a beautiful thing to hear. So what message do you have for women out there who, number one, don't know where to go, number two, have been accustomed, or they have been sort of like, quote unquote, forced to think that pain is normal, and number three, when it comes to seeking help, what would you say, having gone through this journey to be where you are today?
Okay, so first I would say pain is not normal. So if you're in pain, kindly seek medical attention, get the root cause of whatever is causing pain so that you get it addressed, because we are not here to suffer. That's number one. Number two, if you're looking for solutions of as to why or where to get help, I emphasize that you look for someone who is professional, someone who has experience in that area, and someone who is willing to work with you through that journey, who is empathetic, who has a keen eye, and someone who will take care of you, because you need to be taken care of. And then the last thing is open up on whatever you're feeling.
Yeah.
Don't hold it inside. Someone might help you when you say, maybe I have this and this and this. They might help you. Maybe they have gone through the same, or they've known someone who has gone through the same, and they might help you and assist you to navigate the issue. So don't keep things to ourselves. Let's open up. Yeah.
All right.
And heavy bleeding is also not normal.
Absolutely.
Yeah.
And just the way you said, you've shared your journey and your story with us this morning, which I'm pretty sure has helped so many other women who don't know what to do or where to seek help. So for that, we say thank you. Thank you so much. And all the very best. Callers there, so that we can come and babysit.
Thank you.
When that happens. And we really wish you all the very best in that journey as well. And there is a few comments for you. This is on YouTube Live. So Jacqueline Sally says, thank you, Dr. Emal. You have helped so many ladies. I have been battling endometriosis and adenomyosis, and Dr. Emal has been helping so much. All right. And then Christina Lenjo says, great conversation here, great insights. Thank you, Dr. Emal, for sharing this knowledge to help women struggling with adenomyosis and other reproductive health challenges. And I know 1 hour is not enough to exhaust all this. Conversations surrounding adenomyosis treatments are here in the country. So what will be your advice to, first of all, women? Speak to the women this morning as we end the conversation on adenomyosis. And also, number two, what is your hope for treatment as far as the future is concerned for adenomyosis? Because, like you said, some are not available here in the country, and some might be too, costly for so many women to afford.
Thank you. I mean, my parting shot, my summary would be, number one, adenomyosis is not fully understood. Adenomyosis is not universally characterized and staged in a very standardized way. Adenomyosis will require lifelong management process. Please be ready for that. Adenomyosis has impact on quality of life, on fertility, and on pregnancy. Ultrasound and MRI are very accurate ways of diagnosing adenomyosis effectively. Medical treatment should be the first line of treatment always. When pregnant, these women require a high-risk pregnancy follow-up, not routine. And usually combined treatment is employed. Like you've heard here, so there's surgery, then medical suppression, then fertility treatment. So it's combined. And finally, it's important that they are usually in combination with endo, adeno, fibroids, etc. And in many patients who've had endo surgery, even in the best of hands, when the symptoms persist, many times it's because of the adenomyosis, because the uterus was preserved, but every other endometriosis was removed. The patient persists having symptoms of heavy and painful periods. They think the endo is causing it, but it's the adenomyosis.
It's the adenomyosis. And speaking of the same, Faith Jepchumba on Facebook says, good morning. I did an ultrasound, but it was normal. So is it adenomyosis? Is it endometriosis? Please help me. And how can I be diagnosed well? I have lower back pain and painful cramps that sometimes I gasp for breath and I vomit at times.
So that's not normal, and her ultrasound for sure is not normal. I can tell you, but it requires the right eye to see it. So endo and adeno scans are a specialized skill that we are already training people in the region for, because we need more of these to be done so that we don't miss out. So I can almost tell you, if that's the symptom, almost tell you for a fact, her ultrasound is not going to be normal.
It's not going
There's
to
something there that's just not been picked up.
Okay. And since we have the end to end the conversation, is there a way that people can maybe reach your office just to get more, say for example Faith, to just come and get
I would say they could contact Third Park Hospital. That's our center for endometriosis and adenomyosis. And I think they'll be directed from there on how to get help.
How to get help. Thank you so much, Dr. for your time this morning. And again, let's keep the conversation going on our socials. It doesn't have to end here on your TV, but let's keep it going on our socials, and that is at NTV Kenya, both on Facebook and on X and on YouTube as well. But for now, allow us to say goodbye. Dr. Yamal Patel, consultant obstetrician gynecologist from Third Park Hospital. Thank you so much for great insights. Please come back again so that you can help us with so many other conditions, that's gynecological conditions, I want to say, that we can address. But for now, enjoy the rest of your viewing, and we'll see you tomorrow morning, same time, same place, right here on Your World for Trendy Thursday, and we'll be talking about how to dress your body type. You do not want to miss that conversation. Stay tuned. But until then, goodbye and God bless.